I'm here to present our group project, a randomized, multi-center, parallel group, triple-blinded, active drug comparative non-inferiority phase 2 trial to test the efficacy and safety of cannabidiol versus ibuprofen in the relief of menstrual pain in females living with primary dysmenorrhea.
The etiology of PDM is not clearly understood, but studies suggest that endometrial cells release prostaglandins that act as a myometric stimulator and vasoconstrictor. The standard of care treatment for PDM is variable, with evidence showing that NSAIDs are significantly more effective in treatment of PDM than placebo, but with an increased risk of side effects.
Although most PDM patients have shown improvement with the use of non-steroidal anti-inflammatory drugs, studies report that 20 to 25% of women are unresponsive to first-line medical treatment. Cannabidiol is suggested as an alternative.
We hypothesize that CBD will provide a rate of relief of menstrual pain not less than that of ibuprofen, with less potential side effects.
We have chosen a non-inferiority design to evaluate if CBD can be alternative to standard treatments. We do not believe it would be ethical to compare CBD with placebo, since this would imply leaving patients without treatment when there is already an effective option. We have chosen not to compare against hormonal contraceptives because this would involve adding another birth control strategy, and because some guidelines do not put them as a first choice. We opted for ibuprofen as an active control, since it is a widely used NSAID.
Inclusion criteria: women 18 to 40 who have been diagnosed with PDM, negative pregnancy test by BHCG, patient not trying to become pregnant at time of screening or in the following 4 months, women with regular menstrual cycles within range 21 to 35 days.
As for exclusion criteria, we did not include in our study women that were taking hormonal contraceptives or any other drug for dysmenorrhea or with an IUD, women that were pregnant in the year previous to the study, breastfeeding or had an abortion or miscarriage, with gynecological surgical interventions, or obese.
In the flow chart of our study, we will recruit and screen target population in the university clinics from calendar, considering the high cost of conducting clinical trial in the US. For patients who meet eligibility criteria, we will randomize them into 2 groups, following blinding procedures, and then allocate pregnancy and treatment kits to them.
For the intervention, we're going to use UVD tablets, and for the control, we're going to use ibuprofen tablets. For the primary outcome, which is pain relief, we're going to measure it using a top par pain relief scale. And for the secondary outcome, which is a composite of the use of breakthrough medications, quality of life, and the reporting of severe adverse reactions.
Non-inferiority margin, the expected effect in pain reduction is set at 20% measured by Tolbert 16.49 with significance level of 0.05. Sample size of 78 patients for 20% margin, alpha of 5%, beta of 20, and statistical power of 80%.
Primary outcome, parametric one-sided unpaired t-test.
As secondary outcomes, we evaluated the change in menstrual pain intensity between the baseline and the 3 following cycles, using one-way ANOVA. We also evaluated the use of breakthrough medication, a binary outcome, using a chi-square test of independence.